Good evening, everyone. Welcome to our part one of the Billing and Coding series that we're hosting as part of the NANS Residents and Fellows section. My name is Dr. Samantha Irosa. I am currently an attending at Columbia doing interventional pain and spine. So we're super excited here. We're going to run through some of the introductions, and we have a great list of panelists here who are going to cover a bunch of modalities. So I have the pleasure of introducing first up Dr. Morgan Pollard. She completed her anesthesiology residency and pain medicine fellowship at the Mayo Clinic in Rochester, Minnesota, and then went and started her own private practice in her home state of Oklahoma, where she has 2 offices currently. Today, she'll be representing spinal cord stimulation, but she also does do peripheral nerve stimulation and microdosed intrathecal pump management in her practice. So welcome, Dr. Pollard. Thank you for joining us.
Thank you.
Next up, we have Dr. Ali Mohammed, who completed his residency in PM&R at NYP, Columbia, and Cornell. He went on to do his pain medicine fellowship at Brigham and Women's, and is currently also in private practice in New Jersey at 2 locations. There's the multi-specialty orthopedics practice called Advanced Orthopedic Sports Medicine Institute. He's also at a standalone interventional pain medicine practice, the Gramercy Pain Center. He specializes in peripheral nerve stimulation, and today he will be representing that modality during our discussion, but also does some spinal cord stimulation as well as intrathecal therapies in his practice. I'll turn it over to Dr. Jay Carey to introduce himself and the remainder of our panelists, but thank you all for joining us tonight. We'll jump into an overview of what to expect shortly.
Good evening, everyone. My name is Jay Carey, and I'm an interventional pain physician at the University of Maryland. I did my residency training in physiatry at the Baylor College of Medicine, and then my pain fellowship at Johns Hopkins. It's my privilege to first introduce Dr. Pritesh Topiwala. He's an interventional pain management physician and anesthesiologist at Brigham and Women's. He's the medical director of the Brigham and Women's Foxborough Pain Management Clinic. His clinical interests are neuromodulation and interventional oncological pain treatments. He finished his anesthesiology residency and pain medicine fellowship, both at the Brigham and Women's Hospital. So thank you, Dr. Topiwala, for joining.
Glad to be here. Thank you, guys.
Lastly, we have Dr. Michael Stout, and he's a functional and epilepsy neurosurgeon at Beaumont Health in Detroit. He is an expert in numerous neuromodulation therapies for treating various chronic pain syndromes, but also offers specialized treatments for various movement disorders, with treatments including but not limited to responsive neurostimulation and deep brain stimulation, which is what he's going to be representing today. Following his residency training at London Health Sciences Centre in Canada, he received dual fellowship training in functional and stereotactic neurosurgery at Albany Medical College and Case Western Reserve. So thank you, Dr. Stout.
Thank you.
All right, now I'll turn it back to Sam.
Great. So here's a brief outline of what we'll be covering tonight. We're going to go into some of the basics of ICD and CP10 nomenclature. Then we're going to jump into different payer types. And then the real, meat and potatoes of this discussion is going to be hearing from our panelists and all the expertise they bring. So we're going to have a full discussion and then have some time at the end for questions. So if there's any thoughts or questions, you can certainly put them in the chat box. We'll probably try to keep them to the end so we can kind of keep up with the discussion, but we'll certainly leave some time to address those. Next slide. All right. So here's a brief overview of, when we're thinking about the significance of ICD-10 or CPT codes in our practice and kind of really breaking this down to a basic level here. But when we think of the ICD-10 codes, which stands for the International Classifications of Diseases, we're really thinking about what are we treating? What's the patient's diagnosis? And so here in this chart, I've just kind of broken it down by one diagnosis, but then also the 4 modalities that we're going to be hearing about tonight. And so here are some examples. And for example, G57 being sciatic neuropathy. And if we wanted to use peripheral nerve stimulation to treat this, we'd go ahead, order the procedure, obviously do the procedure, and then to bill or to get reimbursed for this, we'd need to use a CPT code, so the current procedural terminology. And so there are tons of CPT codes and of course, hundreds of thousands of ICD codes, but really you want to make sure that you're using the one that is approved, but also applicable. So in the example of peripheral nerve stimulation, we have CPT 64555, which is going to be percutaneous implantation of a neurostimulator array of a peripheral nerve. And important to note here, when we are using this code, we also want to make sure that we're billing for the quantity. So if you drop 2 leads, then also billing for both leads. I won't go through and read this chart to you, but certainly this meeting is going to be recorded and also post on the NANS RFS YouTube. So if at any point you need to refer back to some of the details, you'll be able to see that recording. But in general, we'll see in the next slide some more kind of examples for each of these modalities. Specifically for spinal cord stimulation, here's some more common things that it's used for. But first we have, lumbar post-laminectomy syndrome, radiculopathy of the lumbar region, peripheral neuropathies related to diabetes, certainly complex regional pain syndrome. And while those are ICD-10 codes, we then think, okay, what are the CPT codes that we're going to use to bill for the procedures that we're performing? And each of these varies, whether you're starting with the trial and then moving on to the implant. And certainly if this is a more surgical case or we're doing a paddle lead, the CPT code is going to vary. And so referring to the Centers for Medicare and Medicaid Services is always a great resource to, one, make sure that you're using the treatment and the device for an approved diagnosis, but also making sure that you're billing with the proper code. And so in the example of peripheral nerve stimulation on our second chart, we just have a couple of other ones. And again, there are so many and dozens of ICD-10 codes, and this is constantly being expanded upon as we have new research. But again, listed in the CPT section, some of the more common ones that we see for percutaneous implant versus an open implant. And then, of course, we have CPT codes for revisions or explants as well. So feel free to take a snapshot of this. Again, this will be posted on the YouTube. So we'll go ahead and move on to the next slide.
So I want to reiterate what Sam sort of discussed. So the goal of today really is to provide broad strokes, just to understand some of the main themes discussing common ICD and CPT coding terminology for these neuromodulation therapies. These codes are readily available from national organizations and even your healthcare system. So rather than get bogged down by the minutia, I just want you to sort of understand some of the common themes with these therapies. So for intrathecal drug delivery, I sort of simplified it, and the common diagnosis codes you utilize are 2. So first, you always need to mention the primary diagnosis code for what the actual pathology is, and the secondary sort of subsequent deficit, for which is largely what we're treating. So in the cancer context, the primary pathology would be the primary cancer type, and then the subsequent deficit is typically the cancer-related pain diagnosis. And that sort of carries on regardless of whatever you're treating. So for spasticity, the primary pathology is the central nervous system lesion. And there's actually not an ICD-10 code for spasticity. There's actually numerous. So you want to make sure you identify the ICD code that's sort of very specific to that patient pathology. So for example, spastic hemiplegia in the cerebral palsy context is actually codified a little bit differently than quadriparetic spasticity after anoxic brain injury. And then lastly, other chronic pain. You want to always mention the primary pathology, whatever that may be. And then the chronic pain syndrome ICD code G894 is commonly utilized. And when we sort of talk about the CPT coding for intrathecal drug delivery, there is a lot of specifics that we really need to focus in on. For example, when we talk about screening tests, whether you're utilizing a single shot or catheter trial, and whether you're utilizing imaging or not, that actually corresponds to 4 different CPT codes. So sort of paying attention to those things really helps sort of save yourself when you sort of looking at the back end with reimbursement and authorizations. And similar to spinal cord stimulation, implantation has a separate code for the catheter and the pump implantation itself. And then when you look at refill, analysis, and programming, there are actually 3 separate codes regarding the mishmash of what you do with analysis only, or whether you add programming and a refill component to that encounter as well. Next slide. And so for deep brain stimulation, some of the main themes are there are three indications that really have the most robust evidence bases that it's utilized for. And these are Parkinson's disease, essential tremor, and epilepsy. There are two other conditions that it is used for, but not technically approved for. And these are dystonia and OCD, or obsessive compulsive disorder. So just by that nature, if your patient sort of falls in the latter two cohorts, there may be a separate process for authorization or getting reimbursement. And when you look at the CPT code, much akin to the spinal cord stimulation, once again, you're looking at separate parameters with the electrodes and the pulse generator. And the other thing that I'll always look out for is the number of electrodes utilized. So there's two separate codes for the number of the type of pulse generator utilized, whether that's a single or multiple electrode array. And similarly with stimulation leads, whether you're using one or multiple electrode arrays, and whether you're using intraoperative electrode recording or not. That sort of pans out to 4 separate CPT codes. And similarly to intrathecal drug delivery, there's 3 separate codes corresponding to analysis and various levels of programming that you're performing in that single encounter. Next slide. And so we can actually have a whole webinar series for just payer sources. So I just want to provide a broad strokes framework for payer sources, because this really helps dictate how patients get authorization for these neuromodulation therapies, but also helps dictate reimbursement for you as a provider, but also for your facility. So some of the main themes is for payer sources are to determine whether it's a public source, and largely that's Medicare and Medicaid, and often can also involve the military, whether you work in the VA system or whether you get community referrals from the VA system. And that actually is a bit different than private sources, which are largely employer individualized plans. And these comprise the numerous commercial payer sources that we're all familiar with, but that also includes workers' compensation, which could be favorable or unfavorable for these neuromodulation therapies, depending on your specific system. Next slide. So the main things to really understand when you're sort of navigating payer sources, and this can get a little hairy, is to understand the process for prior authorizations. So I'm talking about approvals, denials, but also an opportunity for rebuttal, because these prior authorization processes can actually vary quite differently with respect to the specific insurance that your patient may have. Secondly, you always want to look over and review the local coverage determinations. So this is determined by the CMS. So largely it does apply to Medicare and Medicaid, but oftentimes commercial payers actually follow suit and determine coverage based on the LCD in your area for specific neuromodulation therapies. And lastly, you want to recognize the covered indications. And this could follow CMS LCDs, but also commercial pairs sort of protocols. But we're in a neuromodulation space where it's new and exciting, and there's always new therapies that are coming around, and you want to understand what the insurance companies sort of dictate for these different therapies. For example, if something's dictated as an experimental status, that already puts your patient and your neuromodulation therapy in a separate stratosphere as far as getting the necessary approval and prior authorization for, versus something that's more commonly approved. Next slide. So we have 3 questions that sort of span the continuum of patient care, starting with how to obtain approval to how to actually sort of get the necessary go ahead to do these procedures. So I'm going to pass these questions on to the panelists and really open up the floor for an open format discussion, and have what they have to say and hear what they have to say regarding their specific neuromodulation therapy. So the first question we have is, what are the common ICD-listed diagnoses that you utilize for obtaining approval for your specific neuromodulation therapy?
Dr. Vali Mohammed, do you mind kicking us off here?
Yeah, no, absolutely. So I'm going to be representing the peripheral nerve stimulation side of things. So I think something that's really important when we're talking about ICD-10 codes is, first off, just talking about what's approved, right, based on your carrier. and then usually documenting some evidence of chronic pain syndrome along with that. And I think that holds true for spinal cord stimulation, a lot of other the neuromodulation therapies that we're discussing. So usually chronic pain syndrome will be included in my diagnosis. The main thing with peripheral nerve stimulation that differentiates it from, say, peripheral field stimulation is that you need to name specific nerve. So oftentimes, I'll be doing a diagnostic nerve block, or at least discussing which nerve I think is involved that's damaged, whether that's based on clinical findings, distribution of the nerve, which is targeted, or nerve conduction EMG. So I will name that said nerve. So say, for example, there's evidence of a suprascapular nerve injury with shoulder pain in a chronic shoulder pain patient. I'll document the ICD-10 code for suprascapular neuropathy, and I will put chronic pain syndrome. Oftentimes, I'll also find myself seeing if the patient will fall into the Budapest criteria as well for CRPS, especially if it involves a joint with peripheral nerve stimulation. If they do meet the criteria, that may be an ICD-10 code that I use. And then neuropathic limb pain is also something that I will use as well as for ICD-10 code. Just again, thinking in terms of this when I document, I guess, pulling it all together in my neurological exam, I may document, if there's hyperalgesia or allodynia or atrophy in the named nerve distribution to kind of bring it all together and kind of pull it together so it doesn't make it difficult for the people at the insurance to deny this for you.
Thank you. Dr. Pollard, do you mind telling us what
Sure.
your most common are?
Sure, yeah. So very similar, but slightly different for spinal cord stimulation. I think similarly, you have to list two diagnoses, chronic pain syndrome typically being one of them for the majority of my patients, and then the secondary code. The most common ones I end up using are either post-laminectomy syndrome, complex regional pain syndrome, especially as previously mentioned, documenting the workup, the physical exam findings. And then I think it's really important if I'm doing anything that's not fitting those two, I have kind of a short list of diagnoses that are on my local coverage determinant, and just making sure that before I offer a therapy to a patient that their feasible ICD-10 diagnoses would most likely cover that for the patient.
Dr. Topiwala and Dr. Stout, can you sort of comment how this applies to intrathecal drug delivery and DBS?
Sure, yeah. So from an intrathecal delivery standpoint, I'm mostly working with cancer pain, and so most of my diagnoses codes are related to some metastatic cancer of X organ. So that's kind of the primary code, and then related to that is the deficit or the cancer-related pain. I basically use that for all of my pumps that I'm doing when they're cancer-related. I also do some baclofen pumps, and so from that standpoint, I'm kind of commonly using the, as you outlined, Jay, the initial insult or pathology, as well as some version of spasticity related to that. For intrathecal pumps, it can get, you can basically get almost anything approved as long as you've kind of shown that there's some chronic pain syndrome associated with it. But it does require, and I'm sure we'll get into this, what are some common issues with getting them approved. So I'm not going to get ahead of myself.
One of the nice things about deep brain stimulation is that it's a bit more streamlined or sometimes more simple than doing pain procedures in terms of documentation. You had a great slide beforehand talking about ICD-10 codes. And so really the 3 FDA-approved indications we look at are essential tremor, Parkinson's disease, as well as epilepsy. Specifically for epilepsy, epilepsy can be broken down into kind of a litany of different subdivisions, but it's only approved for partial or focal epilepsy and not for generalized epilepsy, even though we do use it for that under experimental or under investigative indications. The other two you put up about used in but not approved for dystonia and OCD. So those actually have HDE approval, so the humanitarian device exemption approval. They don't have the robustness of data that the other 3 indications do have, but there is good high quality data generated from RCTs. And so the FDA did recognize that these are conditions that are rare, but are still effective for use for deep brain stimulation. So as long as you can support those indications with data and clinical notes, usually from your neurology and psychiatry colleagues, you can often get implantation done for dystonia and OCD. But that being said, often in the DBS space, we're working with neurologists, sometimes primary care practitioners who might manage things like essential tremor. And these patients have been followed for many years. It's very uncommon for a patient to just show up in a neurosurgery clinic saying, I have essential tremor. I would like to talk about deep brain stimulation, although that does happen from time to time. And so it's nice because these patients often come up with years of workup to support their ICD-10 code, and therefore you can use those clinical notes and typically notes from neurologists to be able to support going forward with authorization for their procedures.
Excellent. That's great.
Thank you all. Next slide. So I guess just to overview, for today's webinar, we're really trying to create this longitudinal picture of what it would be like in our practices where we have a diagnosis, we want to do one of these modalities, and then, of course, we're going to go through the insurance authorization, we're going to go ahead and do the procedure. So we're really trying to simulate that within our discussion today. So our part 2 of the webinar, though, because it's also very important to this topic, is, of course, reimbursement and the financial aspect of this, both within academics and private practice. So we're going to do a deep dive of that in our second webinar, which should be coming up at some point in June. More details to come. But just to give you an idea of where the trajectory of this is going to go, in case any of those questions came up, we are going to do more in-depth discussion of that come June. So that leads into our second question, which I think is a really important one, because, you know, coming out of training and not having the continuity all the time of, one, evaluating the patient in the office, then being able to put the order in or decide on the treatment plan, then be involved with actually doing the procedure and seeing the outcome, we oftentimes don't have this full picture of the entire process. So I'm curious to hear from our panelists, kind of what are some of the common reasons for insurance denials, and, you know, what other barriers have you guys seen within your practice that maybe we can learn from and, you know, ideally avoid in our practice starting out as early career physicians. So I'll bump this over to Dr. Vali Mohammed to kickstart us. But yeah, very curious personally too, to hear some of your experiences on this.
Yeah, so I think the most important thing to do when you first come out is go ahead and read the CMS guidelines for the location where you live, and whether or not you fall under an NCD, which is a national determination coverage, or LCD, a more maybe restrictive local determination coverage. That's what you kind of need to take a look at. Usually the commercial payers will kind of take their lead from there. And then the next step from there is I'd go ahead and take a look at the most common commercial payers in the area that you participate with. And just read those and understand maybe some of the nuances and differences in your particular area. But using CMS or Medicare usually as the backdrop, because most people will accept Medicare, and that will comprise a large component of a chronic pain population. That's a really good starting spot. I mean, I think the most common reasons we see for denials, at least when I initially got out, I didn't really fully understand what those inclusion exclusion criteria were. And so if you start there by taking a look at those guidelines, which are published online, by the way, and NANS has a bunch of different resources for you as well, you can go ahead and start to create yourself a rubric. And that's where I suggest you kind of start making a template. And I did that kind of for all my advanced procedures. And I kind of included all the inclusion and exclusion criteria, and I went through on each one when I suggested therapy to make sure we've reached all of those steps. And if we haven't, that will also trigger you to go back and maybe try those things. That way you can prevent yourself from going through the arduous process of submitting for approval, getting denials, doing peer-to-peers, all to realize that maybe your carrier doesn't cover something or would require you to have done something initially prior to proceeding, and which will save a lot of your time and precious resources in the office. But again, looking at what are common reasons things are denied is because you don't meet certain criteria, right? So when we talk about peripheral nerve stimulation, you need to have a specific targetable named nerve. So if you're thinking about pain in the medial aspect of the knee, maybe you're naming the genicular nerves and the saphenous nerve. If you're talking about the shoulder, name the axillary and suprascapular nerve. If you're talking about the back for peripheral nerve stimulation specifically, you would name maybe a lumbar medial branch nerve. That is in essence for peripheral nerve stimulation, right? You have by the definition of what it is, right? You have an implanted neuroelectrode right next to the named nerve. You can't do peripheral nerve field stimulation, which is what some people may be doing in their residency or fellowship programs, where we put a neuroelectrode implanted under the skin in a general area. That's very different than peripheral nerve stimulation. You need to understand that nuance and have that named nerve, and that will be kind of imperative for you kind of getting approval for what you're going forward with. The patient usually going to have to have failed 3 months or more conservative treatments, and you have to name the different things that you've tried. So many times, what happens when I come back and look at mine, like, well, we didn't see that you tried, conservative treatment, and I may have named that back in the notes prior. But so something that can kind of help you is if in that note where you're requesting a trial or an implant, you need to list out and document all the things that you've tried. And I try to put the dates too, because oftentimes they'll want you to have tried therapy within the past year, or you need to have been under the care of that provider for a certain amount of time, depending on the coverage determination. So I will list out the patient did physical therapy for these months during this time period for this direct indication and did not respond to therapy. I'll list out the medications. I'll list out the nerve blocks and injections. I'll list whether or not they are or are not a candidate for surgery. And we're starting to see some of these things change with spinal cord stimulation, not yet with PNS. But I think that's an important kind of caveat here. PNS, unlike the other neuromodulation modalities which we're talking about today, the trail is still being kind of blazed for this, and we're seeing kind of the guidelines change as we kind of go with different carriers. And so certain carriers are considering PNS experimental. Bigger carriers like Medicare are covering this and do not document that. So it's important to kind of know those things kind of going forward. Coming back to the named nerve, if you have a named nerve, it's documentation. Literature doesn't really support that if you do a nerve block in the periphery, that necessarily correlates with good outcomes with peripheral nerve stimulation. I tend to do one more to kind of advocate for the patient, but also to kind of show the payer that, listen, I have this named nerve. I did a nerve block. The patient had some type of anesthetic response in that distribution, and that kind of corroborates my assumption that this peripheral nerve is involved in this pathway, and then I kind of use that to do a trial. Depending on your carrier, some may allow you to go directly to permanent implantation, but again, knowing that the direct correlation is there, usually we'll do a trial of peripheral nerve stimulation initially prior to implantation. And so just kind of knowing that and then documenting at least 50% reduction in pain or, improvement in function, reduction in medication, those types of things are very important. I think, while it may not be mandated by all carriers, doing a psychiatric evaluation like we do in spinal cord stimulation and intrathecal therapies is important to do, because you never know if these guidelines are really going to change in the future. And then kind of documenting contraindications. I'll give a little caveat here of some things that I've noticed from state to state. Documenting what type of peripheral nerve stimulation treatment you're doing is very important, whether you're talking about a trial and an implant with plans to go on to that, or whether you're talking about some of these other devices, which are meant to be a treatment for a temporary period. Documenting as such is important because the codes, interestingly enough, are not different for those devices. So you need to kind of spell out what you're trying to do. And I guess I'll stop there because I can kind of ramble on for a while.
No, that was great. That's what we need. We need the knowledge. So thank you for sharing that. Have you noticed a difference in denials when it comes to, the systems that are more temporary versus if you're doing a trial and going to implant? Is there, a difference in higher denials for implants versus the, temporary stim? What has been your experience there?
I have not noticed that difference. What I've noticed is maybe the need for a psychiatric evaluation isn't necessarily there for these devices, which are temporary, which would kind of make sense to me, given the fact that it's not going to be a permanently implanted device and is, relatively, I guess, less invasive, if you were to say. Again, the biggest things I think with pitfalls, with some of this stuff when it comes to denials, is making sure that you request, for the right codes, and then knowing how many codes you can do per year as well, right? So, for example, a lot of these carriers will approve 4 leads per year for PNS, and I think that's really based off of spinal cord stimulation, right? We do a dual lead trial, and then if it's successful, we go to implantation. And so many carriers will have like a 365-day rule, not year. It's not like it resets, with, the passing of the Earth around the sun, but it resets, 365 days. And so if you're putting more leads than are covered, you may get a denial because you didn't know that someone had placed other leads, or you're gonna have to document why. I think it's also important with this as well, kind of trying to document as we go forward, kind of blaze the field for peripheral nerve stimulation, documenting what type of nerve stimulation you're going to do, just like we would with SCS, say doing high frequency or tonic stimulation or burst. Documenting what type of stimulation you're doing, I think is important. So whether that's going to be motor stimulation, say when you're talking about multifidus activation, or whether this is going to be for peripheral nerve stimulation, for L3 medial branch nerve stimulation, depending on the device you use, you may need to document accordingly. And so if the ICD-10 codes aren't there that we just talked about previously, you will get a kickback. So making sure that, again, that you kind of have that correct ICD-10 code verbiage there.
Amazing. Thank you so much. I'm jotting down notes here as we speak as well. Dr. Pollard, can you share your experience when it comes to dorsal column SCS with, some of the insurance denials and other barriers?
Sure. So I think there's a couple of different things to think about as far as making sure you're minimizing denials. One is whether this is commercial or Medicare, for kind of a broad division of how I kind of divide up in my mind when it comes to the trial for the first step. So for most commercial insurances, you have to submit for prior authorization. For Medicare, for trials, you don't, but it's very important to know that Medicare specifically, you can do a trial, but you always need to make sure you're familiar with what's covered in your area, because you could feasibly do a trial on somebody and then you want to go do an implant in a hospital. Well, now an authorization is required now in a hospital, not in an ASC. So you can see it gets complicated quickly, but feasibly it's possible to do a trial on somebody that does well for a non-covered indication and then not be able to get their implant approved in the hospital. The other reason is you really don't want to be offering anything, obviously, to any individual patients that can't be covered for the implant. But additionally, even if you're doing these things in an ASC where you don't look at the authorization situation, you still want to make sure you're following everything as written in these guidelines, because you don't want to run the risk of the facility being audited or your practice being audited and having to give money back for procedures that were not actually indicated. So that's kind of a Medicare thing, because with Medicare, like I said, there's less denial, but you have to make sure, and the burden is on you to make sure the documentation is all correct. Whereas with the commercial plans, you typically submit for authorization, which is a double-edged sword. It's kind of a good thing to get an authorization back. You feel like you have some legs to stand on. Of course, that's still not a guarantee of payment, but typically the trial denials that I'm seeing are from the commercial plans because of these very simple but nitpicky little nuances from plan to plan. I kind of have the top probably 5 payers in my area in my mind, but then there's always these little minor payers in the area that kind of sneak in. And the 2 most common things I've seen lately, for example, are needing physical therapy dates with notes, and it may be that the patient has had this long debilitating course and has had 5 back surgeries and 5 physical therapy courses, and the last PT was 2 years ago, but you have to wrestle up those PT notes or send them back for more. And then another common one is if they're not a surgical candidate, you need to produce the note that they saw a surgeon who agreed that they're not a surgical candidate. And then finally, another one I've seen within the past year is needing to spell out what the Oswestry Disability Index is, or the ODI. And this is something that all of the psychology evaluations that I refer for, they always check that. And so it's always in that psychological evaluation, but it seems like they don't read it. They make us turn it in for authorization. The payers don't read it. I don't know why. And then we have to then appeal and say it's in the note on page 7 and their ODI is 21% and they qualify, or whatever the percentage is. So those are just some common things that I see for the trial. And then it seems like if you pay attention with all of these things and get the trial approved, You just document the improvement if it's applicable to the patient, and then they may take their time on the authorization for the implant, but it should go through then.
That's interesting. You mentioned that because I'm seeing some of that for just like epidurals, what were their PT dates, and having to ask the patient that sometimes gets granular, and, the recall isn't always great, but that's good to know. And then regarding the ODI, is that something that you had discussed with the pain psychologist that you work with, or is that something that they just started to do as part of their practice? Now I'm thinking maybe that's something that I
Yeah,
should
I mean, it's
talk.
a good question you're asking. I use 2 or 3 different psychologists, and all 3 that I've seen their reports back all include the ODI. So I don't know if that's kind of standard on their end, or if I just got lucky and they all did it for me.
Oh, well, that's something that I'll be asking for.
Yeah,
Great. Thank you.
sure.
Dr.
And Dr.
Tucker.
Tomala, I know you sort of work in a very niche area with cancer and spasticity, but any thoughts as far as denials and sort of some of the common barriers you've seen?
Yeah, no, I mean, I think intrathecal therapies, and in the context that I'm using them, are fairly. I don't get that many denials, but I do kind of reiterate. I mean, I think the theme that both Ali and Morgan were saying was, documentation is so key with any approval for any procedure you do, whether it's an epidural or trigger points or or a pump. And so specifically to pump, I mean, my documentation includes kind of the using this as a treatment for severe chronic intractable pain of malignant or non-malignant origin, and then I kind of try to outline that a life expectancy of at least 3 months. The general kind of don't want to be placing these pumps in patients that are have a prognosis of days to weeks. The other kind of big portion of it is pain that's been refractory to opioids.
Sorry, I think your audio cut off.
All right, sorry, so sorry about that. Yeah, so the kind of refractory pain to kind of less invasive medical therapy, including medications, interventions, chemotherapy, radiation, those types of things. And then to kind of echo the, having a evaluation by, or at least a note from, an oncologist if you're dealing with cancer pain, or a neurologist if you're dealing with multiple sclerosis, or somebody that the primary specialist that treats that pathology. It's very useful to have and necessary to have. Let's see, and then the other aspect of kind of non-cancer pumps, the trial and proving not just to the payer but to the patient that this is actually viable therapy. So documenting a valid trial.
And trialing of the cancer population, I know, sort of has a lot of controversial opinions and thoughts. Have you sort of seen that be deemed a requisite or prerequisite for intrathecal drug delivery?
I haven't had an issue with going straight to pump in cancer pain. And I know several of my colleagues, like Shane Brogan out in Utah, never does a trial. Galati will probably do a trial or 2 if he's doing pumps, or some of the other kind of cancer patient. I mean, at the Brigham, we generally do a trial because a lot of our patients are on extremely high doses of opioids by the time we get to them, and so the trial is so effective or so useful in weaning some of the systemic opioid down to the neuraxial opioid. And so that's I like the trial aspect of it if we have them inpatient, but as an outpatient, I really don't want to. When I'm dealing with these patients, they have a prognosis of 3 to 6 months, and so taking away an inpatient trial or taking away time from that patient to admit them for a week-long trial or 3-day trial is kind of it just doesn't feel right. The option of intrathecal, single shot spinals is there, where you can do a kind of intrathecal dose of an opioid, just monitor and document efficacy there right in the clinic is an option for kind of for both cancer and non-cancer pain pumps.
No, that's really great advice. I know this is a challenging population and really time is of the essence. Dr. Stout, what about DBS? What are some of the common reasons you've seen denials?
So there's probably two common reasons. One is inappropriate diagnosis, and the other is inadequate documentation or supplementary material. So we talked about the ICD-10 codes being like a pretty small pool, but that being said, essential tremor is a very specific diagnosis, and there's many different types of intention tremor. You can have an intention tremor because of having had a stroke, post-stroke tremor. You can have a tremor due to multiple sclerosis. And to be honest, we do DBS in those patients, even though we can't promise the same efficacy as essential tremor, but that's not a covered indication, and you have to be prepared to fight something like that. Obviously, things like secondary Parkinsonism, are not going to be approved. So Parkinson's disease is usually a pretty uniform diagnosis. And then something I alluded to earlier, epilepsy is only indicated in focal onset, even though we quite often use it for generalized epilepsy. And you have to have medically refractory epilepsy. So you have to have failed 3 different medications. So when you get down into the weeds of every specific diagnosis, you need to understand there are specific supporting criteria. And so if you have the correct diagnosis, but you're still getting denied, that means that your proposal, your submission didn't have the appropriate documentation. So each of these diagnoses, especially tremor and Parkinson's, have specific subscales. So we talk about ODI for pain. Well, there's actually tremor rating scales. There are Parkinson's rating scales. The UDPRS is a multi-dimensional rating scale for Parkinson's. And some pairs, I think BCBS actually has a very specific, you have to have a score of 30 on the motor subscale. And so you wouldn't know that unless you read the documentation in the BCBS. And so every single pair has a little nuances, little differences that you will come to know when you get denials or read ahead of time if you know what type of insurance patients have. So typically, when I'm submitting for deep brain stimulation, I kind of try to hit on the same points. So for essential tremor, they have a disabling tremor. Usually there's documentation from their neurologist saying there's a specific scale showing they have a disabling tremor. They failed X number of medications. They don't have any other neurological condition that would support an additional diagnosis outside of essential tremor. They have a strong family history, and again, so significantly disabled. You keep saying that, and then it seems the more you say it, the more insurance will be helpful to support it. Same thing with Parkinson's disease. They have to have the cardinal symptoms of Parkinson's disease, so tremor, rigidity, bradykinesia. Usually you have to hit 2 of those specific diagnoses. You have to have had good response to levodopa. Typically, or almost always, Parkinson's patients will have something called on-off testing, where they come into their neurologist completely off medication, so the worse that they are. Then they test them, they look at that UPDRS scale, and then they give them their medication and see how good they get. And that's a good indication how patients will do well with DBS therapy, but it's also a necessity for most payers to have that documentation. So good response to medications, cardinal features of Parkinsonism, and progressive symptoms. So as long as you hit those specific milestones, and often if you look at insurance documentation, they have bullet points showing those specific milestones, you'll almost always get approval and never have any issues. And then again, for epilepsy, even though we do generalize, make sure that you're saying these patients have failed medications. They have to have failed at least 3 medications, and then it's a partial or focal onset epilepsy.
That's really valuable information. So you mentioned the need to sort of have some objective data with regard to these different scales. Does it matter where they're derived from, whether it's from neurology, neurosurgery, or physical therapy?
No, it doesn't matter where they're derived from. Typically, the neurologist is most familiar with the scales. In essential tremor, I alluded earlier that primary care physicians do often manage these patients, and they're not doing these formal scales. But again, you look at some of the insurance documentation, and they will say a description of major disability, and that's enough to go forward with authorization and having failed or been refractory to medications. So I would say the neurologists are most used to doing the scales, but no, anybody can actually do the scales and support the documentation.
That's very valuable. Thanks again. Next slide. So finally, once we've sort of gotten past the barriers to getting these authorizations for these therapies, the last question is, what exactly is the process of getting insurance approval once you've sort of submitted for it, you've had the necessary documentation. I want to sort of dig into some of the logistics on behind the scenes from the office staff to actually getting the word back from the insurance company. So I was hoping that everyone would sort of provide their insight and their sort of specific practice patterns.
Sure. So I'll start us off with regards to getting insurance approval following, documentation and, my note being done. I think the biggest thing is make sure your note's done, right? That's a big problem in general, just making sure you're documenting and going back and not leaving those notes unlocked and just really getting all those details in there because that's the worst when really you just haven't finished your note and you get a denial. I think we've all had it kind of happen to us once or twice. But so get everything done, submit. I think for some of these higher level procedures, such as peripheral nerve stimulation, for me, at least in my practice, I kind of know based on my carriers, remember with Medicare, everything's going to go through. Initially, no one's really going to be regulating you. So you may want to have a system of checks and balances internally because you don't want to find out when Medicare audits you at some point and does what's called a clawback and then charges you, a multiplier and then a fee and an interest. That's not something you want to go through and then, sends it on multipliers. And, they're kind of cracking down in general in pain medicine for all of our procedures, epidurals, facet blocks, and kind of see this nationally now. So you just want to make sure your I's are dotted, T's are crossed, maybe make an internal list that maybe your coordinator or scheduler looks over, or maybe that you yourself, when you're making your surgical list for these more advanced procedures. That's recommendation number one. And then again, just making sure that all those things are in place. I think when it comes to just kind of speaking about audits and things like that, I think having that direct indications that you documented in your note that recommends the advanced procedure, in this case, peripheral nerve stimulation for my section here, I actually take that indication and that patient's specific nuances. And when I do my op note, I'll go back and I'll just copy and paste those direct indications. That way, if someone ever goes back to look at this note and the implant, it shows my direct indications that are right there. And so you oftentimes, if you've undergone an audit, they'll come back and they'll look at initially, at least your procedure notes. And it makes sense when it has everything right there. It just makes things a lot easier. You don't have to go searching for all that information. Again, making it very upfront. But when it comes to commercial payers, I personally have kind of learned it sometimes makes sense for me to kind of partner with industry for whatever device that I'm particularly going to use. And oftentimes you have to realize what your rights are when it comes, or the patient's rights are when it comes to getting approval through insurance. So, you're going to have a certain level of appeals, say if something gets denied, and then the patient's going to have a separate level of appeals on their behalf. And so oftentimes what I'll do is I'll have the patient kind of partner with industry to kind of sign a release to have them advocate on behalf of the patient. And if they get a denial, they will submit a host of primary articles, all the documentation, and kind of a lot more leverage behind it, and understand that you kind of have that right to kind of kick that up a level. So oftentimes I'll use that to my advantage to try to get approvals for this, and they can kind of give you some kind of guidance on, what it is that you would need in order to get something like this approved. Another thing I'll just kind of say is just make sure, specifically with peripheral nerve stimulation, there are some devices that are approved for, say, like acute pain, but they may have FDA approval, but they don't have, they're not covered by commercial insurers. So make sure that, those, types of things are kind of thought about. And if you're thinking about implementing that type of arena, say for someone for post-surgical pain who also has chronic pain, make sure you're documenting your ICD-10 codes, understand the global period, say for PNS, for example, is 10 days, even with, trial or implant. So making sure that you're outside of those global periods, making sure that you're not using ICD-10 codes that may fall into a bundled payment plan. So this would be falling under, say, like an arthroscopy code, arthroplasty code or something of that nature. And those are kind of my big things. I think something not noted here that I'm just going to throw in is just understanding your site of service and the cost of the goods that you're using. So specifically for PNS, one could easily argue that permanent implantations could probably be done in the office. However, typically, unless you have a really, really good commercial carrier or payment plan, the cost of goods for services will restrict you from where you're doing it. And understand that when you submit for insurance authorization, you need to submit for the site of service, whether that's office or ASC or hospital. and that certain carriers may or may not approve or pay a certain amount. And so you need to be kind of somewhat aware of that, because it may be cost prohibitive to do the procedure in one location versus another. So in general, peripheral nerve stimulation needs to be done with regards to implantation, at least in an ASC or hospital. Certain systems are feasible to do in the office for a trial. But again, just understanding the cost metrics behind that prior to proceeding will kind of prevent a lot of like delay and back and forth.
Thank you so much. That was a lot of really solid gold information there. I think we could get into, I'm realizing, several webinars just to this question. I'm curious from a private practice perspective, and Dr. Pollard, maybe you could speak to this since you started your own, but how did you end up getting the flow for insurance approvals? Do you have like a separate person that's just doing all that for you? How did you contemplate that process when you were getting started?
Yeah, so this has been a little bit of a process because when I first started, I was able to really oversee a lot of it and kind of guide my hand through almost every aspect of it. And then a good problem is you get busy, right? But then you don't have time to oversee everything. So what we've done is lots of different iterations in my practice, but what we're currently doing and seems to work the best is that I have essentially MAs in clinic with me, as well as my nurse practitioners. And we have one medical assistant that essentially spends 3 days a week doing nothing but working with our we call them pre-surgical patients. So pre-spinal cord stem, peripheral nerve stem, any procedure that may eventually go to the OR. Starts and ends with her. So she spends a lot of time with them. So if we identify somebody in the clinic, and let's say that I have identified this patient for spinal cord stimulation, my medical assistants will send a message through our EMR to the specific MA that submits all of these cases. And then we give the patient actually a handout and say, look, here is what we've identified you for. Here's a little more information about it. Here is the process. This is dictated by insurance coverage, and we have to do the psychological evaluation. Here's their phone number. You should hear from them in X amount of days. If you don't, call them, call us, we'll sort it out. And then, if there's some lab work, we kind of include that step. If there's approval with insurance. And so all of those patients get a phone call from my medical assistant that coordinates these. So we call her like the surgical coordinator. So they get a phone call from her within 3 to 5 days, just touching base. Did you hear back from psych? Are you on blood thinners? Make sure everything is tidied up. And then she kind of guides them through that process, which has streamlined and worked a lot easier instead of the patients having a question, calling in, and they could call into either office. And then every time they call in, some MA is having to take a message, start from scratch, look back through their chart, ask us a question. Whereas we found that just kind of centralizing it with one person, and it's a lot of her time is 3 out of 5 days a week, but it's kind of paid off by trying to streamline that. And it's made the turnaround time from identification to trial and from trial to implant a lot faster. So that's kind of the whole process as far as it goes for us.
Thank you so much for sharing. I'm in academic practice, and so I have, I was very curious how you were able to get that set up, but thank you. Dr. Stout, Dr. Tapawala, what is the situation at your institutions?
Yeah, so from a pump standpoint, if I'm catching them in the outpatient setting, whether this is a kind of onc or a spasticity patient, I'll bring them in. It's usually a referral from, the specialist or palliative care. My main goal with, outside of the appropriate documentation that we talked about earlier is organizing the logistics of it, and from everything from patient education, smoking cessation, and I kind of hand that over to one of my nurse educators I've trained in doing this, or one of my PAs that's very comfortable doing it if I don't have the time for it. So to kind of it's kind of like echoing Morgan's piece of the pre-surgical patient. Education is key, and getting the patient familiar with the entire process and what to expect is so key with having good outcomes from a patient feedback standpoint and just from a gratification standpoint. I order all the imaging that I may or may not need, especially if the pump is a go, whether I need updated lumbar, thoracic, or even cervical spine imaging, depending on where I'm going to put this catheter, psych eval, and then at that point I'm also documenting and at least for myself, my future self, is the contraindications. What's their chemo regimen? What's their how are their labs affected 2 weeks after chemo? When am I going to do this, and how am I going to coordinate with the oncologist? Prognosis is so important in what I'm doing with the pump, with the cancer pumps. And so that question is you'll never get a good answer from anyone on that. So, you got to have a little gestalt there and at least ask the question or to the oncologist, and it's so variable. And then anticoagulation is so, almost all of these onc patients are on have some hypercoagulability. So that's always a concern. I book them for a trial if there's spasticity, or maybe they're an onc patient that's kind of borderline. But most onc patients I don't book for trials. So I'll kind of book the trial, and then I'll do the trial, and then finally follow NAC guidelines for implantation, which are, I think, so key in this. The MRSA swab, the Hibiclens, the perioperative the appropriate antibiotics, and then book for implant. But it all starts with the education and the kind of the flow, like getting everybody, kind of gathering the herd, especially the patient, on what to expect over the next X weeks.
So sort of sticking to the theme of how valuable time is in this population, just from a logistical standpoint, are you sort of waiting to hear back for approval before you sort of proceed with scheduling and getting the procedure done, or do you sort of just preemptively get the process started from your institutional standpoint for scheduling them?
Okay, so the onc pumps I'm seeing inpatient, so I'm basically booking, and it's usually hasn't been an issue. From an outpatient standpoint, I give 2 weeks, and if it's an onc patient, I'm not always getting a psych eval. I'm not always doing a trial. Actually, I'm rarely doing either one of those. And it hasn't been an issue. But again, this is a completely different population than the chronic pain population. And so if from a baclofen or a chronic pain standpoint, I mean, those are key, and time is not of the essence, I guess.
Mm-hmm. That makes sense. Dr. Stout?
So DBS is a bit different compared to pain, obviously. Pain, you guys are often on the ground floor. So when I do stimulators and pumps too, it's you starting the workup often. For DBS, we're often the tertiary referral. So we're seeing patients after they've been worked up, after they failed medications. We're seeing them as the final step before surgery. Sometimes we do see them along the way in terms of telling them what surgery is in case they're scared about getting a brain surgery. But again, we're usually the final step. So I've done this in both private practice and in academic practice, and the steps are usually the same. The partners are usually the same. And really what we want to do to make sure we get insurance approval towards the end is to kind of have a set of criteria leading up to a surgical consult. And so this is a small field compared to pain. So DBS, if you're doing 4 a month, that's very good compared to how many implants you could be doing a month for spinal cord stimulation. So the workup takes a bit longer. It's a bit slower, and in that way, you're less likely to kind of missteps and make sure you have all your information for insurance approval. So when I meet a new neurologist, either in the community or in the hospital, and we talk about, well, you want to get involved in DBS, what kind of experience might you have? And then we talk about, well, your types of patients that you're going to refer for this procedure. Again, what kind of criteria do you want to meet? And so we talked about in the last topic, for insurance approval, we talk about meeting those rating scales, meeting the medication testing, and all those criteria that are in the insurance authorization. And so what I try to emphasize to my neurology colleagues and my primary care colleagues is that before these patients come to me, they should have already met those criteria that you have gone through with them. And so then by the time they get to me, the only discussion I have is basically what are surgical risks, what is surgical efficacy, and then my last step is often just ordering a very specific MRI for surgical planning on like a 3T scanner. So we've tried to make that as streamlined as possible, and that usually works pretty well if you're willing to engage your colleagues in the community and in an academic setting. And usually they're very receptive to that, and it makes for just a very smooth transition into from diagnosis to identifying patients to actually implanting.
So really, you need to harbor good relationships with your neurologists, it sounds like, to make sure that they streamline care from them sending appropriate referrals your way. And surely everything should be nicely ironed out by the time you see them.
Functional neurosurgery is working with pain, physiatry, neurology, and epilepsy, and we wouldn't be anywhere without our relationships with all those specialties.
Well put. Next.
That was, I think, a great way to segue into our audience questions. I think it's been amazing hearing from all our panelists here. We have a multidisciplinary team that's been just dropping such valuable knowledge over the past hour. We're running low on time, but please put some questions out there if you have them. We'd love to kind of pick the brains that are a couple minutes longer and hear from our panelists a little bit more. I guess while we wait for some questions to come in, I do have one maybe that we can end on and do like a rapid fire through all of our panelists. But what's one thing that you all wish you knew starting out in practice? Was there ever a moment where either, not that something went wrong or a specific case, but you're like, man, wish I knew that, when I started? Might be a hard question, but any piece of advice to leave our audience, knowing that probably mostly trainees and some early career docs?
I'll start with this one. Because I do so many implants in so many different parts of the body, I think it's very important to develop a good relationship with your device representatives out of the gate. Wherever you are for training or fellowship, I would ask them, if you're going to be staying in the area or moving to a different area, who those people are, connect with them, find out what the local market is like, find out how you can interact with local physicians, with other people and other devices, and they will lead you to career success.
Excellent advice. Thank you.
I'll jump in with a little pearl. I think anytime, you're looking first, especially when you're first starting, you're gonna be super eager to go somewhere. And just understand that culture is probably the most important thing, in my opinion, right? Money, success, all that stuff will come, but entering into a place where everyone else seems happy, right? The ancillary staff, the other docs, that's extremely important. You're gonna be spending so much time at work, arguably equal time that you'd be spending home with your own families. So really ensure that you kind of vet out the location, taking maybe a suggestion for a job somewhere at the recommendation of a colleague or a friend. I would take that much over, an arbitrary, increase in salary, right? All those things can be renegotiated. Culture is extremely important.
Thank you.
I would say something really practical, and it may not be all that possible while you're in training at an academic center, but if possible, either before you leave training or whenever you start at your new practice, regardless of practice setup, if you can figure out how to talk or spend time with somebody that submits for insurance authorization for procedures that we do, and someone that bills for procedures that we do, I think that will clear up a little bit of what that process is. For me, starting my own practice, at first, that was just a black box, and I really had to seek out some resources. So if you have a chance to do that, the more you can actually understand about the boring and tedious processes of getting those things done, the more you'll understand how to document appropriately and effectively the first time, and you'll understand whenever those people come back and ask you questions, they don't understand what we do clinically. It's, I think, easier for us to reach into their world and maybe spend a day looking into it, making notes, and then you'll know when you need to ask who questions. And I think it'll just make the transition a lot easier.
Yeah, for me, given kind of the intrathecal pump and area that I'm working in. I really harp on imaging and getting familiar with actually looking at your own imaging, actually looking at the radiology. And if you have questions, talking to a radiologist that like a local radiologist. I mean, I'm in a place where I kind of have the luxury of an on-call radiologist, but getting in that reading room or at least talking to somebody for some questionable imaging is so key, especially with pumps and dorsal column stimulation too. I mean, the thoracic imaging is valuable and can save you some complications and save you a bunch of headaches if you see some thoracic spine disease that wasn't caught earlier.
So I have a separate question. You hear about these horror stories, whether it was miscommunication or what have you, where authorization wasn't appropriately received and you thought there was, and you perform a procedure. So can you sort of talk about the back end of that? I mean, does the patient receive a massive bill on their doorstep? Does the hospital or your institution need that cost? What exactly happens in scenarios like that?
I mean, I think it depends on the scenario. I've seen that happen a couple of times. And in large part, it was because the commercial payer did not require an authorization before a trial. And then we went to implant. And then they came back and said they denied, for example, peripheral nerve stimulator implant because the patient had not documented to have tried a TENS unit. So some of these things, if you figure out the reason for it, you can just appeal it, write a letter, call, whatever it says to do, and state the patient did in fact try and fail the TENS unit. In this case, kind of silly, the one that comes to mind. But I think in other cases, if it's continually denied after you can try to retro authorize things or appeal. Then unfortunately, if it's a facility, it almost becomes a conversation between the facility administration and the patient because the doctor is really not at the table financially there.
I'll address this from a more experimental indication angle. I do a lot of craniofacial peripheral nerve stimulation, which is obviously not covered. I do a lot of deep brain stimulation, responsive neurostimulation for epilepsy, for generalized epilepsy, which is also experimental. Document. Despite it being experimental, there is still evidence. There are still papers out there. For some instances, there are ongoing studies. When they've come back with denials, we kind of fight it full court press, especially with epilepsy. We get the epileptologist involved. We get all the documentation saying why this is a medical necessity. For craniofacial peripheral nerve stimulation, often they'll approve a trial, but not the permanent implant because of the generator. And then we go back and fight again with documentation. In neurosurgery, we have occipital nerve stimulation guidelines that we've published. And so I'll always put those guidelines in there, things like that, just having documentation and keep fighting. So far, we haven't lost an appeal for something that was already implanted, although obviously for some things up front, we've had difficulty getting approval for.
Yeah, I mean, I'm in the luxury of a really large academic center, and so I think that some of it just gets eaten by the facility. You can do retros, or you can do kind of letter of medical necessities post, or things like that. But sometimes it just doesn't get approved.
So we have one more question via the audience chat, and out of respect to our panelists, I think that'll be our last. But someone asked, is there sort of a common source where they can sort of find the most commonly used ICD-10 codes and the requirements and verbiage for bread and butter procedures, as far as requirements goes and sort of prerequisites?
So maybe I'll start with this one. So if you go to the CMS, you type in CMS into Google, and then whatever procedure you're looking into. So in this case, peripheral nerve stimulation, spinal cord stimulation, intrathecal therapy, deep brain stimulation, that should generate, national determination guidelines for you, which is what you're going to be looking for, or an LCD. And from there, it'll tell you basically all the inclusion exclusion criteria, the level of evidence which they've given the therapy, and the typically approved ICD-10 codes, which are associated with that therapy, as well as the implants, trial and revision codes. And it's kind of like a good, starting place. So especially, that's where I would start, and just know that separate, guidelines will exist and determination coverages for each commercial carrier. So again, once you've established yourself in a certain location, understanding what those those determination coverages are. If you're really avid about neuromodulation, also be sure to do your due diligence, as Dr. Stout said, about where you're going. Maybe talk to some of the device representatives and make sure that, the locale that you're going to, covers the type of therapy that you're, passionate about performing, right? Certain places in the country will consider, for example, PNS, experimental, or DBS experimental for certain things, or spinal cord stimulation may have certain restrictions. So understanding that can kind of help. It's a bit confusing, but that's usually where I start for anything. And it kind of going to something I wish I knew. Just realize that it all kind of unfortunately comes back to the ability to pay for these procedures. And so you need to look to the payers, in this case, insurance, to see what their determination coverage is. We may have evidence for something, and typical things that we may consider to be an obvious way to proceed forward with some type of intervention, but you have to kind of play their game to essence. So knowing what those are ahead of time will prevent unnecessary documentation, over documentation, under documentation, and kind of get you to the nuts and bolts of what you need to do.
Okay, we actually have one more question about DRG stim, but that actually works out okay, because our next webinar, where we take a deeper dive, actually includes a panelist for DRG stim. So I apologize, but we're out of time, and we'll definitely be able to answer that in more depth next time. So that concludes our webinar today, and I want to extend a heartfelt thank you to all of our panelists. This was extremely valuable and informative. To all the attendees, this is recorded, and this is something that's readily available to you later on. And with that, thank you all, and have a great night.
Thank you all. Good evening.
Thank you.